Welcome back to part 4 of this Introduction to Clinical Governance lecture. So this time we're going to go through pillars 4 to 7, which are clinical effectiveness, staffing, staff management, education and training, and there's a little bit of overlap between those two, use of information incredibly briefly, and premises standards. So before we do that, I've just got to get back to this question, which is health and safety is one aspect of the risk management component of clinical governance for community pharmacies. List 5 areas of H&S risk in community pharmacies for which staff should create risk assessments and or receive training, and this is a sort of question you might get in an exam. And there's your answer. So if you put any of those 5 down, you would have got 5 marks. So this is just to give you an idea of the sort of questions that you might get. Just to give you a bit of practice and to help you to remember what this is all about. So these are all the aspects of health and safety which you're going to need to do training for and create some risk assessments in a pharmacy. And when you go out there, if you go and do a placement for any length of time, you're going to be going through all this stuff. Okay, so let's go on to these extra pillars of clinical governance. So the first one's clinical effectiveness. And so this is what it's all about. It's the 5 R's. So making clinical practice more evidence-based and providing the best service. And we do that through the 5 R's, which is doing the right thing in the right way, at the right time, in the right place, with the right outcome. The right outcome is obviously what we want. So doing the right thing in the right way, this is thinking about all the training that you're going to be doing so that you know about making evidence-based decisions and having the best information available to you and using that information, and it basically means that you're going to have a very skilled workforce to do the job in the right way. And then at the right time in the right place, this is about accessibility to services, making sure that your services are easy to get to and at the right time, and then the right outcome to maximise health gain. So in the NHS contract, we've got this sentence at the top, so a clinical effectiveness programme, which includes arrangements for ensuring that appropriate advice is given by a pharmacist in respect to 2 things. So one of them is about repeatable prescriptions, so this is your counselling, and then also to people caring for themselves or their families, and that's your self-care angle. So these are the 2 main places in community pharmacy where we provide advice to patients. So you can see these, it sort of can be split into 3 sorts of things really. So not only are you giving clinical effectiveness, you're improving clinical effectiveness of prescribing by counselling patients, and this could also include the new medicine service where you do counselling at the start, but also thinking about prescribing intervention. So you're looking at the prescription to begin with and making sure it's safe. So you're giving advice to the prescriber, so it includes that angle as well. So this is doing your clinical check on every prescription, and this is where the NHS contract ensures that the pharmacist does the clinical check on the prescriptions. So to do that, you've got to be aware of all current guidance and evidence. You need to know everything about drugs, and you've got to know about monitoring patient care as well. And then finally, with your self-care advice, this is your responding to symptoms that we're doing in PAMS, and you'll be doing in OSCEs later on, which you'll absolutely love. And in a community pharmacy, not only will you be providing advice over the counter to patients, and certainly the pharmacist gets involved in the more complex types of advice and trains up their staff to be able to help them with advising the simple requests, but also something called the CPCS, which is the Community Pharmacist Consultation Service, teaching you about that in the 2nd year. And that's the service that we're paid for. It's an advanced service, and it's where patients are referred to you from both NHS 111 through the emergency out of hours system, and also from GPs to community pharmacies for minor elements. So this is where we give self-care advice to patients because we've been referred patients from other NHS settings. And this is just really to say that this also incorporates all the training of your teams to be able to refer patients back to you. So this is part of Day Lewis's training for our medicines counter assistants and pharmacy assistants, where any patient that is a bit more risky is referred to the pharmacist to give over-the-counter advice. And there's a whole list of things there. And this is just really thinking about the prescriber intervention. So this is where a mistake's been made by the prescriber. And this is your clinical check that you're doing in PAMS and will be doing in a pharmacy once you get qualified. So you clinically check your prescription, you have a look at all the interactions, and if you discover a potential problem, wrong dose, wrong strength, wrong medicine, then you're going to gather some extra information before you contact the prescriber. So you're going to ask the patient about the prescription, perhaps. They might know something that means that there's not a problem, or they may not know and there may be a problem there. So you counsel the patient, you might get other information from the PMR of the patient or from the summary care record of that particular patient. You might find information about that particular medication from looking at the SPC. You might want to look up that particular disease, you might look in the BNF, and you might look up current treatment guidelines, maybe look at NICE guidelines, CKS, all that kind of stuff. And then you're going to contact the prescriber if you need to, and this is your inform, suggest, request that you're going to do in your PAMS. And of course you've also got the new medicine service, which is where you're talking to patients, you're engaging with them, and this is a three-step process. It's an advanced service, but most pharmacies would do this, and with certain medicines, which are those for asthma and COPD, for diabetes, antiplatelet and anticoagulant therapy, and medicines for hypertension, then for any of these conditions, when a patient rocks up with a new medicine for any of those conditions, then you will counsel them as you normally would, and that's the engagement part of the service. And then a week later, you're going to talk to them again, and that's called the intervention stage, and you're going to talk to them about how they're getting on with their medicine, and whether they've actually taken it, and if they've got any problems, whether they've got any side effects. And then you talk to them again 1 or 2 weeks later, and that's the follow-up stage. And by talking to them on several occasions, it means that patients become much more adherent, and you also identify any problems with their medicine that might have not been identified at the start, and they may have stopped taking their medicine because of that. So the patients will tell you about the side effects that they've experienced, and you can help them to deal with it or refer them back to the prescriber if it's something quite nasty. So that's a really good service, and it's all part of clinical governance, in that you're counselling patients and increasing your clinical effectiveness. Okay, so here's a question for you. Clinical effectiveness for pharmacists is best described by the following definition. Have a read and decide which one's the best one. Okay, well, I hope you've made a decision. So you could say that out of these, clinical effectiveness could be described as probably D or E, but the best description is E. Okay, so then going on to the next pillar of clinical governance, which is staffing and staff management, education and training. And for community pharmacy, we've got some contractual obligations that we have to follow regarding this. And this is probably a little bit hard to understand unless you've been in a workplace, because these are things really to do with work. But these are enforced by the contract, because of course clinical governance is one of the essential services, and we have to make sure that we comply with all of this. So if you're a pharmacist manager, then you are responsible for all of this, because you are that responsible pharmacist. But as it comes down to it, if you work for a big company, then usually all of this will be dealt with by the company and by the management structure of that company. So firstly, you've got to have sufficient staff with appropriate qualifications for the level of work. So if you get inspected by the GPHC, they will check this and make sure that all of your staff are qualified appropriately. And if they're not qualified, then they need to have started a training course for that particular qualification. So for pharmacists, obviously you've got to be a qualified pharmacist, and you've got to have those qualifications in place. If you're looking at your dispensary staff, they've got to have started on the dispensary assistant course, which is an MBQ2, and they don't need to be qualified, but they have to have begun on the course, or at least started an induction programme. So it's making sure that everybody has those appropriate qualifications for the type of work that they're doing. If somebody's working on the counter, then they need to be doing an MBQ2 for the medicines counter assistant course. So they've got to also have enough staff hours to do the job. So you've got to have enough people. In the drug tariff, it's laid out what is the minimum number of people to have for the number of prescription items that you do per month. And this is the minimum dispensing staff level in hours per week in the dispensary. And included in that is even pre-regis. But this is the absolute, and it's here in this table, this is the absolute bare bones minimum that you can get away with, and most pharmacies would have more staff than that. And we've also got help with all of this in a GPHC guidance document that came out fairly recently, which is guidance to ensure a safe and effective pharmacy team, and we have to work to that too. So we have to check qualifications and the identity and references of people when we employ them. And this is a problem sometimes, in that healthcare workers might not be who they say they are. You do occasionally get an imposter. So you have to make sure that when you employ pharmacists that they've got their GPHC registration and it's up to date. And you have to check passports and national insurance and all of that sort of thing for every worker in the country, actually. But for pharmacy, it's making sure that pharmacists have got this GPHC registration, and making sure your other workers who claim to have various qualifications, you need to see their certificates and make sure it's actually the case. We also have to provide an induction for new staff and for locums, that's pharmacists and technicians, to make sure that they know how to operate at short notice. So as soon as they arrive, for new people, they're going to be going through all that health and safety training that we talked about in the part 3, and learning about confidentiality and all the details of your SOPs, all that sort of thing. So there's usually an induction programme for every member of staff. It has to be in place, and the GPHC will inspect that. For locums, you have to have something that's fairly quick to read, because they're only going to be there for the day maybe. So it has to be something brief. And they're not going to go through all your health and safety training, but they might need to know where the fire exits are. So appropriate staff training. So all staff have to be trained or undergoing training, which is what we discussed for point number 1. And you have to make sure that there's all the details and documentation available in your pharmacy of the training requirements of your staff. So you have to have a staff matrix to say what qualifications everybody has and how they're trained for the level of work that they're doing. And all of this has to be documented with assessments and all the certificates for everybody available if needed. You've also got to make sure that you identify and support any development needs, and this is all about doing annual reviews, at least annual, for your members of staff. So in Baylewis we actually do every 6 months, we do a review on all of our staff, and this is to see what other training people might require and to make sure everything's up to date. And if people are getting through their training very slowly, then you can identify that and action it. And then also just to quickly say that pharmacists and technicians have to be able to demonstrate a commitment to CPD, and this is really something that's not only part of staffing and staff management, education and training, but it's about clinical effectiveness as well. I'll put a slide on that in a minute, and also thinking about remedying poor performance, and these are all our contractual obligations as part of this pillar of clinical governance. So just to think a bit more about clinical governance being about continual improvement, and to again reiterate that CPD is part of clinical effectiveness and staffing and staff management, because we want to make sure that our staff are as well trained as possible so they can do a great job and provide the right advice to patients. So CPD is mandatory for pharmacists and for registered technicians, so any GPHC registrants. And we also do routine clinical training for the whole pharmacy team, and this is thinking about the medicines counter assistants having to continually update their knowledge as well on medicines that come out for over the counter. And if they don't know what to advise on, then you're not doing a very good job in your pharmacy. So there's continuous training at all levels for all members of staff on clinical matters and everything else besides. And pharmacists obviously get inspected on this, as do technicians, because they have their mandatory CPD submission marked by the GPHC. And then you've got other training as well. So it goes on forever. So other trainings needed to be accredited to provide various services, and those can be essential, locally commissioned or advanced services. And we do all sorts of things. A lot of it's training through CPPE, which is the Centre for Pharmacy Postgraduate Education. Some of it can be through other bodies. So I've put here the NCSCT, which do training for smoking cessation. We've got safeguarding local training that we have to do, and also we do a lot of training for PGDs, which you'd have to do before you provide services like the flu vaccinations, which are provided on a PGD, and there's training that you have to do before you can do the PGD. And then we also have declaration of competence, which is something that's filled in on the CPPE website, that is something that can be seen by NHS England if you're providing services for them. So a couple of those declarations of competence are for vaccination services and for providing emergency hormonal contraception services, but there are many others. So that's just to let you know about that. And when you become qualified, you'll be filling in those declarations of competence, and this is really a huge, massive training that you do for those services, and you're showing that you have all your evidence together and all your certificates in one place for the NHS to see what you've done. And then finally, just to talk very quickly about the Pharmacy Quality Scheme, which is this scheme that I mentioned where you get paid for basically doing loads of training and audits and all sorts of other things. And the training within that helps us to continuously improve. And it's not just pharmacists that do that training, but within PQS there's training for the whole pharmacy team. So with the most recent iteration of it, there was training for weight management in patients at a level 1 weight management training scheme, which was done by every member of staff. So this is just to show you one of the CPD records for the GPHC that we have to submit. This is an example that is on the GPHC website. I know that you're going to be doing CPD yourselves as part of your undergraduate course. So I think you get some lessons on that, and then you have to learn how to do it, and you have to submit things to your PAD portfolio, and that will be marked in your third year. Okay, so then thinking about remedying poor performance. So occasionally this does happen where you have perhaps a pharmacist who is not really doing a very good job, and there might be a number of reasons for that. So firstly, it has to be identified that the pharmacist isn't doing a good job, or it might be another member of staff, could be anybody. So you've got to have a staff management structure to be able to identify when a pharmacist isn't doing a good job, unless the other members of staff want to say something, and the likelihood is they're not going to, because that's their boss. So you've got to have support mechanisms in place for your staff when things go wrong, and that means giving them the best chance of doing extra training, turning things around and improving. And you would be able to identify problems by doing your staff performance reviews as well, and to see what's happening with your staff. So management would do those, and they'll be able to identify any problems and then address it by doing various, getting the staff member to perhaps do some extra training or be supervised, or all manner of other things that they might have to do, work to shadow another member of staff for a while, all that kind of thing. And sometimes that improves, sometimes it doesn't, and then you have to go down other HR routes to deal with that particular member of staff. So we also have to cooperate with local poor performance arrangements to deal with somebody who's not doing what they should be doing, with NHS England, the GPHC, or accountable officers, or even the police. So this is when perhaps you've got a pharmacist who's taking drugs, or who has perhaps made masses of errors, and the GPHC have got to be involved, and they're going through a fitness to practice regime with the GPHC, and we have to cooperate with that and provide any evidence that those people require, those bodies require, to make sure that everything is safe in our pharmacies if we've got staff that are not performing well. And finally, it's also part of clinical governance and part of this pillar of clinical governance to raise concerns about our members of staff. So we have to have a whistleblowing policy, and that gives our pharmacy teams, as well as the pharmacist, somebody to talk to at the next level. It's usually your line manager first, and then above them it will be somebody who's outside the pharmacy company that perhaps you can contact if you are unhappy with the way things are operating or about a particular person. And we do have to raise concerns about any member of the team who is not performing well. So this is really difficult stuff. This is to do with work in practice, and if you go to do your placements, I hope you don't see any of this in action, but it's something that you have to learn about and learn how to manage, and it's actually really difficult. It's one of those extremely difficult parts of becoming a pharmacist, is that you have to deal with all this. The use of information pillar, I'm not going to give you very many details on at all, because you've had a sort of a brief introduction to this in your first year to deal with going on placements. So I had a bit of a chat to you and gave you some examples of what to do with confidentiality and dealing with patients' data. But really you get a huge lecture on this, a 2-hour lecture on this in your third year, and so it's probably just worth waiting until then. And so use of information is part of clinical governance, and so it's an essential service, an essential part of the way in which we operate in pharmacy. Incredibly important, but I'll deal with it in that lecture in the third year. And then also to talk about premises standards. So this is specific to community pharmacy. It's a very important part of community pharmacy because it's the patient-facing side of things, in that your pharmacy needs to be clean and your standards have to be high in any healthcare setting. So obviously if you go into a GP surgery, you don't want it to be grubby. And if you go into a community pharmacy, you don't want it to be grubby either, all dusty and dirty. It doesn't give a very good impression, and it doesn't mean that you're going to be providing a very good standard of care if you're not keeping it clean. Especially for the last year, when we've been fairly fanatical in community pharmacy, because we've still been providing a face-to-face service throughout the pandemic. And so it's been really important that we have very high levels of cleanliness. Pharmacy teams have been spending a lot of time cleaning the pharmacy every day and using a lot of bleach and sanitising absolutely everything. So very important, but you have to show that you've been doing this by filling in cleaning rotas. And so those all, it's very important to show that you have been cleaning your pharmacy, and everything has to be signed off. And that's very much the same in hospitals. They have to do a similar system. So you also have to provide an appropriate environment for healthcare, and that means it's got to be safe and tidy in your pharmacy, and you've got to have enough space to work in. Some of our dispensaries are not that big, and it's very important to be very ordered if you're working in quite a tiny dispensary. It has to be a professional healthcare environment, so not only clean and tidy, but also with the right sort of atmosphere in it. You've got to make sure that you've got the right equipment. So you've got to have computer in your consultation room. You've got to be able to speak to patients and have your clean tables and chairs. Your chairs mustn't be made of fabric these days, because you've got to be able to clean them. As you see there, the seating area quality, it's got to be not only the consultation room, but in the pharmacy, it's got to be chairs that you can wash down with bleach to make sure everything is clean enough for a clinical environment. So all these things are important. And appropriate levels of privacy are also very important and often very difficult to attain in pharmacy. The consultation room is the place to be if you've got anything that is confidential to say to your patients. And consultation rooms have to be of a certain standard, and all of that is laid out in these premises standards as to what the consultation has to be like, in that it's got to be confidential and nobody should be able to hear it outside. And you get somebody from NHS England who comes along and checks out your consultation room and makes sure it's of appropriate standards for talking to patients. And then finally, within these premises standards, you've got opening arrangements. And this is where the pharmacy must be seen to be open by members of the public during core and supplementary hours. And you probably don't know what those are, but basically the core hours are the minimum hours that the NHS asks us to do. We can do a few extra hours, such as working on Saturdays or Sundays, but once we put those in and told the NHS that we're going to work those supplementary hours, then we absolutely have to work them. And also, if the pharmacy is locked during opening hours, then you've got to have limited access to the public. So this is pharmacies that are open until really late at night, and they might have a hatch and a glass screen which leads to the outside of the pharmacy where you can talk through it. But you've still got to have access inside if the patient needs to have a confidential conversation with you. Even if the pharmacist is a lone worker, they've got to have some sort of arrangement so that they can have a confidential conversation. So all of this is laid out in the premises standards, and we have to work to it. And then finally, just to give you a little bit of detail on this pharmacy quality scheme. So I'm showing you last year's criteria because this year it's been very much skewed by COVID, and there's all sorts of things that we have to do which are sort of COVID specific. So this is just really to show you how closely it aligns with the clinical governance arrangements, because we're doing audits. You can see here we've got lots of audits that we had to do. A non-steroidal anti-inflammatory audit, the valproate audit and the lithium audit we did last year. And we're doing lots of things to do with risk management. You can see that we were doing sepsis training, so trainings included, risk management as well to do with sepsis. We were doing some training looking at look-alike, sound-alike errors, and we were writing our annual safety report focusing on these look-alike, sound-alike errors and trying to reduce the numbers of them. You can see also that we were dealing with prescribing, so this is the clinical effectiveness arm here on the right. You've got this where we were looking at all the prescriptions for patients who are on short-acting bronchodilator inhalers and making sure that those without any corticosteroid inhalers were reviewed by their prescriber. And we were also looking at children who were prescribed corticosteroid inhalers and making sure they got a spacer prescribed as well, and looking at their asthma plan. So this was all to ensure that prescribers were prescribing safely. So this is all part of clinical effectiveness. So there's all kinds of things where we were basically doing various aspects of clinical governance through the pharmacy quality scheme. And of course, clinical governance is all about quality, and the pharmacy quality scheme, as in its name, is all about quality as well. So they work synergistically together to raise the quality of the service that we provide in pharmacy. So what you should have learned from these 4 parts of this lecture. So you now should know what clinical governance is and why it exists. You should know about the 7 pillars of clinical governance, and you might want to count through them because you're going to need to know those. And you should also know how this community pharmacy contractual framework, which is our contract, and PQS help pharmacists to implement clinical governance. And I hope we've gone through this in enough detail for you to know all of that. And then finally, just to show you, there are the 7 pillars of clinical governance. Make sure you get those in your head and you know the details, and you should be able to then provide that quality service when you get out there as a pharmacist.